So earlier you spoke a little bit about the inequity and disparities in terms of the care that elders receive. And you recognize this early on in your career as a geriatrician, that you can see the elder population as an underserved population. Now, do you see that changing at all now? And if not, what do you feel needs to happen to provide better care to our elders?
I love that question. I actually saw them as underserved when I was an internist and a general internist, and I realized I had trained, at Harvard Medical School and then at UCSF, which had the best primary care residency. And so in theory, I had the best training in the country. And yet I realized when it came to my older patients, I knew a little bit about some of their diseases, but I didn't know about most of the things that mattered most to them. I didn't understand about how their bodies metabolized drugs differently, about all the different interactions and risks, about the different priorities, which make good sense if you have other diseases or a shortened life frame. I didn't feel like I either had the cognitive framework or the knowledge to take good care of them, and that was how I ended up in geriatrics. But I also noticed that even at the best places where I had trained, there was no infrastructure for that. If you have a sick child and you're in a city, and my career has only been in cities, there are specialized hospitals. There are specialized doctors. Now we know that a 5-year-old body is as different from a 25-year-old body. We recognize 5 is different from 15 is different from 25. We also recognize that 25 is different from 65, which is significantly different from 95. And yet, for some reason, we say it's okay to have pediatricians and internists, but it's not okay to have geriatricians, or they don't really matter. They're an add-on. And I think that's ageism and fear of aging. Now, we mostly got pediatrics in the 1800s and early 1900s, partly because when child labor laws came in, suddenly there was this longer phase of childhood, and people were like, you may remember all those paintings where kids are just made as shorter adults and they look wrong, right? So we recognize this is different socially, emotionally, cognitively, physically. And we've made that same recognition about older adults, but we're somehow not willing to elevate geriatrics. Geriatricians have been part of this problem. I actually think a big part of this problem. Part of it stems from ageism and perhaps a lack of the institutional incentives that made pediatrics, including World War I, where people started to pay a lot more attention to child health so that they would have enough soldiers to go to World War I. Perhaps not the best reason to create a field, but the side effect was a good one. And I guess we haven't had a similar incentive, but geriatricians have said there is ageism, so there aren't enough of us. Because there aren't enough of us, we're going to care for the oldest and the frailest only. At the clinic at UCSF, our primary outpatient clinic, it started as a 65 plus clinic. And that's because old age has been recognized as beginning physiologically throughout history and across cultures somewhere between the ages of 60 and 70. And legally 65 is old age in our country. Because of the huge demand with no advertising ever over the last 20 some years, they went to 70, then 75, then 80, then 85. So then they say, why is nobody giving us respect? Well, you're only taking care of the 85 plus. It's a smaller population, right? It is a small segment of everyone who's old. It is largely voiceless. And it is akin, in my way of thinking, to having pediatrics be exclusively neonatology. Mm-hmm. That's important. It's important how we take care of infants and newborns. But that's not all of pediatrics. And until geriatrics makes itself bigger and more inclusive, it will remain small.
Mm-hmm. Thank you.